Hi, everyone. Denise Wilson here from the Association for Healthcare Denial and Appeal Management. I have a new camera. Hopefully this angle is going to work for you all. I know you're not looking at me, you're looking at the slides anyway. Today on our webinar Wednesday, we're going to talk about readmission denials, and this is something that you all asked for through your feedback that I've gotten from the other webinars that we've done. When we do our little survey at the end, I ask you, what do you want to hear about in the future? And readmissions was kind of a top pick. Number one is still clinical validation. You guys really, I can't believe how long this clinical validation request for education has gone on, but it's just like the number one thing that, payers are using in their audits and denials these days. So we will be doing one on clinical validation in September. I don't have the registration or the details up yet, but we will be tackling clinical validation in September. Today, we're going to do readmission denials. Okay, here we go. All right, so if you're new to GoToWebinar, you should have a sidebar that, or a taskbar that allows you to use either your computer audio to hear me, or you can call in by phone. You can also download the handouts there. If you go to that little taskbar, you should see the handouts. Now, I know sometimes because you're working in a hospital, it may not allow you to download from the website. You can also find them on our homepage at www.hdam.org. You can download the handouts there. Just go to the homepage, the landing page, and right up above the description of the webinar that we're doing today, there's kind of an orange icon there, or button there, and it says, webinar handouts, or fighting readmission denials handouts, I think is what it says. So just click on that. You can try downloading from there as well. If you're still having trouble with that, you can put something in the Q&A panel, the questions panel, and we'll send them to you after the presentation today. So as we go through the presentation, if you have questions about the content today, put them in the questions area, and I will plan on spending the last 10 to 15 minutes answering any questions live that you have submitted. If you're having problems with technical difficulties, put that in the questions as well. I have Alice here today. She's assisting me with the webinar, and she will respond to you if you're having technical problems. Now, you all had a lot of questions from the last webinar we did last month on the simple effective appeal letter, and I haven't gotten to those yet, but I promise I will get to them as soon as I can. I know you're all eager to get your questions answered, and also for me to post the simple effective appeal letter template to the website. So I will try to get that done in the next week or so. CEUs, free CEUs to our ADAM members only. So you need to be an ADAM member. If you haven't joined yet, I'll give you till midnight tonight to join to get your free CEU, okay? You have to come to the live webinar. We do record these. We do post them on our website, usually within a week at the most. So you can go back and watch it anytime you want to, but we do not provide CEUs for watching the recording. It's only if you come to the live session. You will need to complete the survey that pops up automatically for you at the end of the webinar. As soon as you log off or I close the webinar, it'll pop up on your screen. If it doesn't pop up for some reason, just email me. I have my email at the end of the presentation today. It's denise@hdam.org. You can email me and I can send you a Word document where you can complete the survey. And you have to be on for at least 50 minutes, and I give you plenty of time to be on. I start the webinar 30 minutes early, or I open it up 30 minutes early, and I stay on up till the top of the hour at least. So you have to be on for at least 50 minutes according to GoToWebinar. CEU certificates will be emailed to you. Whatever address you use to register for the webinar is where you'll get your CEU emailed to you, and it takes us about a week to email those out because we have to make sure you were on for 50 minutes, you did your survey, and all of that good stuff. Okay, and then as a disclosure, there are no individuals in a position to control content for this activity that have any relevant financial relationship to declare. Now, when you fill out your survey to get your CEUs, you can select from 5 different CEUs. You can select all 5. You can select 1, 2, 3, however many that you're interested in. So we have them for ACTIS, we have them for NARI, CCMC for our case managers, AHEMA for our coders, and ANCC for our nurses. Okay, our next complimentary webinar in about a month is going to be legal arguments for clinical appeals. It's Wednesday, July 20th at 2 p.m. Eastern time. You will get CEUs for add-on members, and you can register now. If you go to our homepage, we already have a registration link set up there, so you can go ahead and register. And I see some of you have already registered for that webinar. So, you know, it's not just about writing a good clinical story anymore. You really have to understand how the payers, because it's really the commercial payers that we're dealing with for the most part, managed Medicare and commercial payers. You've got to understand what the rules are legally, regulatorily, if that's a word, and include that in your appeal so that you are telegraphing your intent to the payer to say, look, we understand the rules that you are to abide by, just as they are trying to hold you accountable for billing appropriately and correctly. We need to hold them accountable for playing by the rules. So this is easy to understand. Even if I can understand it as a clinician, you can understand it. It's going to be simple legal arguments that you can put into your appeal letter. So I'm excited about this one and hope you'll join us for that one. I almost called it legal arguments for dummies, but you know, you get the drift. Okay, it's legal arguments for clinical appeals. You can understand it as a clinician. You do not have to have a legal background to understand it. So that's going to be in July. As I said, we're going to do in September clinical validation. And then in October, we're going to do outpatient services that are covered by NCDs or clinical policy bulletins, and how you appeal those and avoid getting denials for those. We're going to talk about total knee as an example, but you can apply that to really any service that you provide on an outpatient basis that's covered by coverage determination for traditional Medicare or clinical policy bulletin for commercial payers. I don't have anything scheduled for August, and I don't think I'm going to schedule anything for August. I'm participating in the American College of Physician Advisors Town Hall in August. It's going to be about mid-August. They don't have it on their calendar yet, but we're going to talk about managed Medicare, Medicare Advantage plans, and best practices, current state, and there's several very good physician advisors that they have invited to talk at the town hall, and then they've asked me to be there as well to talk about appeal work, you know, for managed Medicare. So that's the American College of Physician Advisors, ACPA. It's free to go to the town hall. They usually have it in the evening. It's like an hour and a half. It's, you know, broadcast over the internet. I don't think they have CEUs, but you don't have to be a member to attend that. So that will probably be my August education. Okay, a little bit about the association. We are the only nation's association dedicated to healthcare denial and appeal management. Our mission is to support you all who are working in denials and appeals through education, collaboration, support. And our vision is to create an even playing field where patients and healthcare providers can be successful in persuading our medical insurers to make proper payment decisions. Me, I'm Senior Vice President, General Research Group, Appeal Masters, and I'm President of the association. I've been in healthcare for well over 30 years. And these days, I primarily manage the association, provide education. I do speaking nationally and also on a local level. So if you belong to any associations and you'd like for me to speak at one of your association meetings, you know, feel free to reach out. I do education at hospitals virtually, or, you know, I would consider going back to doing it in person probably in the very near future. Okay, and then I need to read this disclaimer and then we'll get going into the meat of the presentation today. The Association for Healthcare Denial Appeal Management publishes and distributes materials on its website that are created by our members or invited industry subject matter experts for the benefit of our ADAM members. We do not certify the accuracy or authority of the materials. They are distributed and presented as research information to be used by our members in conjunction with other research that you deem necessary in the exercise of your independent professional judgment. We claim no liability in relation to reliance on the content of the materials, and the views expressed are the views of the materials authors and do not necessarily represent the views of ADAM. Any references are provided for informational purposes only, do not constitute endorsement of any sources. Okay, our learning objectives for today is to identify at least 3 of the conditions included in the Hospital Readmission Reduction Program from CMS. Identify 1 circumstance when a readmission may have been appropriate, and identify 1 method of defending appropriate readmissions through the appeals process. So when you do your survey, you're going to see questions on these 3 learning objectives. I just want to warn you about question number 2. When I say identify 1 circumstance when a readmission may have been appropriate, that means a readmission that you should have gotten paid on, okay? It was appropriate readmission. Not inappropriate according to the payer, okay? Not one that should have been denied, but one that should have been paid, okay? I probably could have worded that a little bit differently. I think you'll get it and you'll understand, because one of the answers is going to be different from the others, okay? So the one that's different from the others, you know, it's going to be your answer. I just didn't want that one to trip you up. Our learning objectives for nurses. Same learning objectives, we just have to write them a little bit differently for the nursing CEUs. They require it written in just a little bit different manner. Okay, so let's get into it. So our Hospital Readmissions Reduction Program, I'm going to start with CMS because that's kind of where this, you know, where we think about when we talk about readmissions, we think about the CMS Readmissions Reduction Program, and it's actually been in place for about 10 years now, believe it or not. And it's a program that Medicare manages that reduces payments to hospitals with what they deem to be excess readmissions. And the reason that it exists, the why, is that Medicare wants to encourage hospitals to improve communication and care coordination. So better engagement of patients and caregivers in their discharge plans, which will in turn, in theory, reduce avoidable readmissions. So it really was a way to look at, are we doing enough when we discharge our patients to have a good discharge plan in place? Are we making sure that our patients are ready to go home? They have all the resources they need? Because the focus was, you know, that's one of the things that possibly we could do better in healthcare so that our patients aren't coming back to the hospital so often. So what CMS does, a little different than what the commercial payers do, is they look at a couple of years worth of data and they calculate a payment reduction for the hospital based on that hospital's performance in the prior 2 or 3 years. They have 6 readmission measures that they look at during that performance period. So they look at those readmission measures, meaning when a patient is admitted with one of those 6 measures, they're going to look at any time a patient is readmitted within 30 days when their first admission was one of those 6 readmission measures. Okay, it doesn't matter why they're admitted for the second time, and I'll talk about that a little bit, but the first time needs to be one of those 6 readmission measures. So they do all this calculation. I'm not going to get into all that, but then they come up with this payment reduction and they apply it during a fiscal year to all of that hospital's Medicare fee-for-service DRG group payments, regardless of the payment or regardless of the condition or the procedure. Okay, so whatever they calculate, they say, here's your reduction payment for the next fiscal year. Every hospital is going to have different. Some will have no penalty. Some can be all the way up to 3%. Okay, that's the maximum penalty reduction is 3% of all of your Medicare payments. They define readmissions as an admission to subsection D hospital. I'll tell you what that is here in a second. Within 30 days of discharge from the same or another similar hospital for acute MIs, COPD, heart failure, pneumonia, CABG, THA, TKA, which I know a lot of the, THA and TKA is primarily outpatient these days. It wasn't 10 years ago when this program was put into place, but you can still have hips and knees, done inpatient when it's medically necessary for that to happen. So subsection D hospitals, every hospital except the ones that are listed here. Okay, so located in one of the 50 states or District of Columbia other than psych, rehab, etc. Okay, and not Maryland. Okay, so Maryland, because you're special. Maryland hospitals are not penalized because the state has federal permission to set its own Medicare payment rules. Okay, so Maryland is excluded. CMS still looks at Maryland readmissions and still calculates them, but there's no penalty. Okay, so the 6 measures that I just talked about, they're going to look at, CMS is going to assess all cause unplanned readmissions within 30 days. So that's what I mean by, they call it the index or initial admission. If the initial admission was one of those 6 that I just mentioned, and then there's an unplanned readmission within 30 days, regardless of why they came back, whether it's a totally unrelated condition, a totally unrelated diagnosis, or whatever, that goes in the bucket and it gets counted. Okay, and then they come up with this adjustment factor, and then they apply that to all of your cases for the next year. And there is, I think, a 30-day, once they post that, there's a 30-day period where you can contest it if you think they've calculated it incorrectly. Okay, so just to give you an idea, the penalties that are in place for fiscal year 2022, which would have started October 1st, 2021, Medicare is reducing payments to 2,500 hospitals or 40% of all facilities. Now there's hospitals in there that don't get, when they say 40% of all facilities, that means there's hospitals that are excluded from the count. The average penalty is a 0.64% reduction, so that's quite a ways down from, quite a ways below, not down from, but below, the 3% max. And fines average about $217,000 for a hospital in 2018. That's what the average fine was. Only 39 hospitals in 2022 are receiving the maximum 3% reduction. And I've got the URL here. You can go and there's actually a link to where you can look and see what your hospital's penalty is for the next year. So in essence, Medicare, traditional Medicare, fee-for-service Medicare, they're not issuing denials, at the time the patient is readmitted. So we're not appealing traditional Medicare readmissions. What we're appealing are everything else, which I'm going to call the commercial plans, which includes Medicare Advantage, Medicaid, Medicaid Advantage, not Medicaid, traditional Medicaid. That's going to be up to your state. So I'm just going to give you one example, Anthem Blue Cross and Blue Shield. I wanted to save plenty of time and room for doing case studies, because I know you guys like to see actual appeal letters in situations where appeals have been successful. So I just picked one commercial plan, Medicare Advantage plan, to just kind of introduce you to what you may see in commercial plans. What did I say? Not process, not guideline. What they stated is their policy. Could come up with the word policy. Their commercial policy. Okay, so this is from their provider manual. So when you're looking at what the commercial plan policy is for readmissions, you've got to refer to your contract or your provider manual, and every payer is going to have their specific policy for what they do with readmission. So when you're appealing, you really have to look at that policy and understand how that payer is going to treat readmissions in order for you to be successful in appealing them. So in this particular case, what Anthem Blue Cross Blue Shield said in their provider manuals, they don't allow separate reimbursement for claims that have been identified as a readmission in the same hospital for same similar or related conditions. So we see that, mostly with, or we see that very often with the commercial payers where they're looking for readmissions for same, similar, or related conditions. But that might not be true for all of them, so you really need to understand that. Typically what payers will do, the commercial payers will do, is they will look at the two admissions, and if they are for same, similar, or related conditions, they'll pay one DRG for those two admissions. And typically they're going to pay the higher, usually they'll pay the higher weighted DRG. But again, it's going to be payer plan specific, and it could even be contract specific. Okay, so this is what Anthem Blue Cross Blue Shield has in their payer manual as inappropriate readmissions. Okay, so same or closely related conditions or procedures as the prior discharge. So things like if they have an infection that occurs or other complication of the care that they received from the prior admission. A condition or procedure that indicates a failed surgical intervention, so they have to go back in because the surgeon left a sponge in, and that would be, or their wound may be dehisced, opened up. An acute decompensation of a coexisting chronic disease. So an example of that would be, let's say if they were brought in or they were admitted for a UTI, a urinary tract infection, they also had chronic CHF, and possibly their CHF wasn't adequately treated, or maybe they were starting to go into decompensation of their CHF when they were discharged, and then they come back because now their CHF is out of control. Any need that could have reasonably been prevented by provision of appropriate care consistent with accepted standards in the prior discharge or during post-discharge follow-up period. So that's a little bit about, your discharge planning, your discharge plan, your follow-up, as well as care provided during the hospital as well. So did they get care that was appropriate, consistent with accepted standards? I talk about that a lot. And did they have a good post-discharge plan and follow-up? And then the other inappropriate readmission is an issue caused by premature discharge from the same facility. So that could be, really roll back to talking about that acute decompensation of a chronic disease. So were all of their comorbidities stable? Was their presenting problem resolved or managed, to a point where they can be safely discharged home? Those are the things that we want to look at when we're thinking about, was the denial for the readmission appropriate or not appropriate? Okay, appropriate readmissions, ones that are okay, is if the patient is coming in for cancer treatments, OB deliveries, rehab care, transplants, newborns, behavioral health, sickle cell anemia. So those are the ones that this particular plan says that's okay for patients to be readmitted when they've got these issues going on. If they're transferred from one acute care hospital to another, that's not really considered a readmission. That's just a transfer from hospital to hospital. If they're discharged against medical advice, that's not something really you have control over. Chances are they probably going to come back with the same, issue, probably in worse shape. I mean, that's what we see a lot of times. They go home, even though they, insist on going home, even though it's better for them to be treated in the hospital, and then they're back in your ER in a few days or a week. Okay, so let's break this down to, I've got kind of 3 high-level areas that I want to talk about when we talk about readmission. So one is whether or not the two admissions are clinically related, because that's what we're going to see for denials a lot of times, is they're looking to see whether they're clinically related. Now, for the majority of denials that are issued by the commercial payers, you may only get an EOB or remittance advice that with a denial code on it, and 249 is a common one that I see, denial code 249, that says this is seems to be, a readmission for the same issue, and they're going to deny a payment for both of the DRGs. It's not that often that you might have a payer. I've seen it with some smaller payers, local payers who might say this appears, they might send you a letter saying this appears to be a readmission for the same issue. Send us your medical record and we'll take a look. But the vast majority of the time they're just going to deny, and then you're going to have to argue back that they were not clinically related. Okay, so we should get paid for both admissions. So clinically related readmissions might be if it's a continuation recurrence of the reason for the initial admission or a closely related condition. In one of the examples I'm going to show you, it's the one for the patient being non-compliant. He really came back for kind of a continuation of the first issue that he was hospitalized for, but he was non-compliant with his discharge plan. So it's hard sometimes to say, well, it doesn't necessarily always have to be that it's not clinically related. There is the argument that the patient was not compliant and didn't follow the discharge plan, and that's why they're back in. So that's one of the categories I'm going to talk about. Let's talk about clinically related. Acute decompensation of a chronic problem that was not related to the initial admission, and that would be the example I gave of the UTI and the CHF. An acute medical complication plausibly related to care during the initial admission, unplanned surgical procedure to address the continuation or recurrence of the problem causing the initial admission, a surgical procedure to address a complication resulting from care during the initial admission. I think that was it for that list. So clinically related, those are just some examples of when a payer might consider that these are clinically related admissions. Let's talk about potentially preventable, and that really goes to your discharge planning, your discharge plan, was the patient stable? Were they not discharged too early, appropriate to be sent home safely or to whatever the next level of care is? So what we want to be looking for when we're arguing that this readmission was not preventable, it wasn't potentially preventable by the provider, because we made an appointment, all the appointments for the patient to follow up within the first week or with an appropriate time frame from discharge from the initial admission. So appointments to see their primary care, appointments to see their surgeon, appointments to see physical therapy or whatever they need post-discharge. Did they get a list of telephone numbers to call so they know if they're having problems? Who did they contact? If they have questions, who do they contact? Did a healthcare advocate or provider do an in-home safety assessment if that was appropriate prior to discharge? Were the written discharge instructions provided explained to the patient caregiver prior to their discharge? And did the patient receive all the required prescriptions? And was the patient or the patient's caregiver educated on appropriate use of the medication? So this should all be pretty routine documentation that's in your discharge plan. And that's what you want to point out in your appeal, to say we did everything that was clinically appropriate to ensure that our patient was going to be successful when they were discharged from the hospital. And here's the record of everything that we did before we sent the patient home. I think I have the same bullet point at the top here that I had at the bottom of the last slide. If the patient needed durable medical equipment, was that arranged for? And then financial and social needs. If the patient had specific financial and social needs that you were aware of, were those needs addressed in the discharge plan? Okay, and the last one, the early discharge. I don't see this very often as really used as a denial reason for readmissions. But if the payer says, if they tell you why they're denying it for a readmission in the first place, which, like I said, the first time around, a lot of times you're just going to get an EOB that says it was denied for a readmission. But let's say you appeal it one time and they come back and say, well, we think you discharged the patient too early. You can appeal that by saying, well, was the patient asymptomatic? Were their comorbidities stable at the time they were discharged? So describing what that patient looked like at the time that they were discharged. If it's a general readmission denial and let's say the payer lists early discharge as an issue that they see for readmissions, just go ahead and address it, in your appeal. Go ahead and talk about the patient's status at the time the decision was made to discharge the patient. Okay, so formulating your argument in your appeal, pay attention to the payer's policy. I've said that many times already. They may include or exclude certain facilities. They may include or exclude certain conditions or diagnoses from their readmission policy. I've seen different time frames for readmissions. I've seen readmissions, for 14 days, 30 days. There's a lot of discussion out there. There's a lot of studies that have been done, a lot of opinions posted about readmissions. What's an appropriate time frame? Are readmission penalties really making a difference in, in the care that's being provided to patients? Are we really saving money by instituting readmission penalties? And so all of that's really, it's not something I'm going to discuss. I just want to talk about how you appeal when you do get these readmission denials. Okay, that's a whole discussion for another day, but I know there's a lot of talk out there about readmissions. Does the payer talk about readmission from the same hospital back to the same hospital or any hospital? And then what are their exclusions to the policy? For example, the Anthem Blue Cross and Blue Shield said, well, if they sign themselves out AMA, they don't hold that against you. If they're transferred from one hospital to another, that's a transfer. It's not a readmission. And then did the payer follow their own policy? Because I always say that's kind of your first line of defense, just as they're trying to hold providers accountable for providing care and documenting and billing in a way that's appropriate for payment. When they come back to audit or deny, are they following their own policy? So that's one of the first things that you always want to check, because that could be a quick, easy win if you can point out that they inappropriately denied a readmission because they didn't follow their own policy. Okay, so let's talk about the three areas. The clinically related, these are the ones that are the issues you're going to argue most often with readmissions: clinically related, potentially preventable, and then early discharge. So clinically related, you can look at the DRGs, primary diagnoses, and obviously, if they're denying based on your claim information, if they compare, you're back in within 30 days and you've got the same DRG as you did for your initial or a very similar DRG, that's a quick and easy, deny from the payer, or primary diagnoses on your claim. Were they different, or are they related? So what I'm saying is, for your argument, you can argue that these were, entirely different DRGs. Not sure why you're even looking at this, because they're not, it's not a similar presentation. Even if the DRGs are the same or very similar, did the focus of care differ for each admission? So because of the coding system, you can come up with very similar DRGs, maybe, but the focus of care for each admission was different, which makes them really not clinically related. Potentially preventable, that's all about your discharge planning, the completion of the discharge, and follow-up. Was that all conducted appropriately? And then early discharge, as we talked about, the patient's symptomology and comorbidities, were they stable at the time of discharge from the first admission? Okay, so clinically related considerations. In your appeal, be exceptionally clear about the events that happen at the first admission versus the second admission, and provide a roadmap. And when I say roadmap, what I mean is that you're going to talk about things that happened in the first admission, things that happened in the second admission, and make sure that you're providing where they can find that documentation. So your payer, when you say that the patient was admitted as an inpatient with the diagnosis of this or that, they can go right to the history and physical on page 39 or history and physical page 38 or whatever. And that's what we mean by a roadmap. Make it easy for your payer to find your argument support in the medical record. Make sure you're focusing on the issue at hand. So the bulk of your appeal should deal with the exact reason why the readmission should be recognized as being independent from the previous admission. Like I said, if you don't know exactly what they're looking at, I would go through all of those. It's not clinically related. It was not potentially preventable. The patient was not discharged early. Argue all of those. Do not just give a compilation of everything that happened during the first admission and a compilation of everything that happened during the second admission, because that's not going to do it. Okay, you have to compare apples and oranges. The first admission was an apple, the second admission was an orange. Different through diagnoses, different focus of care. Okay, so it's like a comparison between first admission and second admission. Okay, potentially preventable. Discharge instructions that use abbreviations like BID, TID, PO, not really helpful to show that a patient was educated adequately. So make sure your discharge instructions that you give to the patient are written in a way that the patient can understand them. Non-patient friendly discharge instructions can be actively used against you. So think about layperson language when you're creating your discharge documents. Look for documentation of, did you set up some telehealth visits? Were post-discharge phone assessments done, or at least were they planned? Look at the care management and discharge planning notes from the beginning of the stay, from the day of admission, because that can really speak volumes about how your team was working from, discharge planning. I've always heard this my whole medical career. Discharge planning starts as soon as the patient's admitted, right? So that can speak to how you had an active case management, care management, discharge planning going on for this patient. Interdisciplinary team communication of patient discharge needs, that helps support that as well. If there were calls made to community providers, outpatient services prior to discharge, that can help support that you're doing everything you can to support that patient after discharge, and your disease management education as well. If the patient left against medical advice or they were non-compliant, those are not preventable, okay? So how do you determine whether a patient was not compliant with care at home? Is there adequate documentation that physician orders were appropriately communicated to the patient? Is there adequate documentation that the patient or caretaker was mentally competent, capable of following the instructions, and they made an informed decision not to follow them? Are there any financial or other barriers to following instructions that are new or not known after the first discharge? So something can pop up, the patient was in the hospital so long, now they've lost their job. They can't afford their medications. They didn't know that. You didn't know that at the time that you discharged them. Was the non-compliance clearly documented in the medical record? So when the patient comes back in the second time, if they were not compliant with their discharge plan from the first time around, it's really important to get that in the record for the second admission, so that you can, at least you may not avoid, that auto denial coming down the road, but at least it will help you with your appeal. Okay, so let's get into, just look at my time here, let's get into our 2 case studies. And again, if you have any questions, you can add those to, enter those in the questions tab, and I'll answer as many as I can live. Were the admissions clinically related? This is not the entire appeal letter. It just doesn't, converting an appeal letter in a Word document to PowerPoint slides just doesn't work very well, but hopefully I'll give you enough information you can, it is snippets out of the actual appeal letter. These are actual cases that got overturned, but hopefully I'll give you enough that you know how to formulate an argument going forward. So Jane Doe was discharged within the past 30 days from an inpatient admission with a diagnosis of COPD exacerbation, and her discharge date was September 10th of 2021. Her DRG was 192, COPD without CC or MCC. Then 10 days later, she came back to the emergency department. And this time, just to kind of skip ahead a little bit, her DRG came out to 189. So it's pulmonary edema and respiratory failure. So related, can be related to COPD, but not in the same grouping for the DRG. So she presented to the hospital emergency department via an ambulance after experiencing chest pain, palpitations, and shortness of breath. EMS found her to have a critically high heart rate of 210 that was treated with adenosine, 6 milligrams, and then 12 milligrams with no improvement. She was cardioverted ×3. The third cardioversion or third shock resulted in a cardioversion. She was supported with assisted ventilations with a bag mask while receiving treatment by EMS. So her diagnosis was acute hypoxemic respiratory failure, respiratory acidosis, hypotension, tachycardia, COPD with exacerbation, chest pain, and chronic combined systolic and diastolic heart failure. Okay, so COPD with exacerbation is in there in the list of diagnoses, but there's a lot of other things going on with this lady as well. So after in our appeal letter, of course, we went through and talked about her presentation in the ED, what her treatment in the ED, what her treatment plan was. But to summarize at the end of our appeal argument is to kind of pull all of that together and explain to the payer why this admission was not directly related, clinically related to the first admission. So she was admitted as an inpatient for further evaluation and treatment of acute hypoxic respiratory failure, respiratory acidosis, hypotension, tachycardia, COPD with exacerbation, chest pain, chronic combined systolic and diastolic heart failure. Okay, all of those diagnoses that she had. Her pulmonary system was supported with BiPAP. The antibiotics that were started in the ED were held because her labs didn't indicate that she had a possible infection, which could be a trigger for COPD exacerbation, but that wasn't the case here. For this admission, the second admission, Ms. Doe was noted to have SVT, supraventricular tachycardia, prompting her to be brought to the ED, and it was treated, that SVT was treated during this hospitalization. So that was the focus of care during this hospitalization. The SVT is what worsened her oxygenation status and led her to her acute on chronic respiratory failure with hypoxia and hypercapnia as the main reason for her admission. So it wasn't really, what we consider to be a COPD exacerbation. It was the SVT that kind of, kicked her over the edge and caused that chronic, acute respiratory failure. And once the SVT was treated, then, her pulmonary issues were improved. And SVT was not part of her prior admission. She didn't have SVT during her prior admission. Okay, so that's our first one. Let's do our second one here. Was the patient non-compliant? This one I thought was really interesting. This was a young guy in his 30s who was discharged within the past 30 days from inpatient admission with diagnosis of osteomyelitis and dry gangrene of the left foot, resulting in amputation of the fourth toe. Discharge date was March 8th of 2022. Prior to that admission, the March 8th admission, Mr. Doe was treated for his osteomyelitis on home IV antibiotics, but the home health agency reported he was not compliant with that treatment plan. And he had a long history of medical noncompliance and poorly controlled diabetes. So get that in the record if you can, because then that definitely helped with our appeal argument on this particular case. So this DRG was 617. So he came in, he had a amputation of the fourth toe on his left foot. At discharge, so this when he was discharged from the first admission, home health was set up to assist with home IV antibiotic treatment and wound care. Follow-up appointments were set. for visits with primary care, endocrinology, surgery, infectious disease. The care team agreed to change his home IV antibiotic from vancomycin every 12 hours to daptomycin every 24 hours because he had been non-compliant with the frequency of the home IV dosing. So you can see where the team was really working to try to accommodate Mr. Doe in getting a home health plan, a discharge plan that was going to work for him. Okay. Then on March 22nd, he was readmitted as an inpatient with a diagnosis of osteomyelitis at the 4th and 5th metatarsal remnants, worsened to gangrene and cellulitis, which had now advanced to the 1st through the 3rd toe. And it was interesting because they had photos from the first admission where those 1st through 3rd toes looked healthy. You could see where, you know, the 4th and 5th toes had been removed. They took a picture after that surgery. Toes 1 through 3 were healthy. Now they come back in and now they're gangrenous. So he came back to the ED. He had worsening left foot swelling, redness, and discharge, and he requested below knee amputation. He said he didn't have any feeling below that knee anyway, and he didn't think it was ever going to heal. And so his DRG is 616, so very close to his prior DRG of 617, because now he's having amputation of his below knee. So the summary of our appeal argument was that second admission was not preventable. He had a long history of medical noncompliance that caused him to return to the hospital and request the amputation. At the time of discharge following his first admission, he had an effective post-discharge plan, but most likely because of continued noncompliance and lack of desire to save his foot, he returned and asked for the amputation, which is what they did. So that's our non-compliance example. And we did get an appeal decision back on this one that says that all discharge planning related to the first admission was appropriate and completed, and the second inpatient stay was not preventable. These are considered unrelated separate admissions. So it's always nice to get a little bit of feedback, even if it's just a couple of sentences, to kind of give you an idea of what that, what that payer will consider for unrelated separate admissions. Okay, so avoiding readmission denials, or at least making them easier to appeal. It's all about the documentation. For clinically related, how is the readmission different from the prior admission? Think about the admitting diagnoses and the focus of care. Potentially preventable, your excellent discharge planning and documentation during the first admission, and any evidence of patient noncompliance or unexpected changes in their social or financial situation that you couldn't have anticipated for that second admission. And then early discharge, just ensuring there's solid documentation of the patient's resolution of their presenting problems and their comorbid conditions were treated and are stable. So our key takeaway points: know the payer's readmission policy and did they follow their own policy? Like I said, that can be your first line of defense and a quick, easy win. Do not assume that the auditor or the payer was correct, and that holds true for all denials and appeals. Look for ways to prove that the auditor was wrong if you did actually get, a letter explaining why they're denying for the readmission, or when you get your decision letter back and they uphold their initial decision. Make sure that you're, submitting both of your medical records. Look at both of your medical records to obtain your complete and accurate information, submitting both medical records. Just don't look at the second medical record and go by what the doctor said happened during the first admission. That's going to be a very brief, abbreviated, summary of the patient's first admission. And then just stay very focused and very clear on what it is that you are arguing in your appeal. Okay, now I've got some references for you. And I'll stop there and we'll see if we have any questions in the Q&A. I guess it's just called the questions tab actually in GoToWebinar. I just want to say thank you to our support team at the corporate office. Thank you, Alice, for assisting me today. And let me go look at our questions tab and see what we've got. I'll pop this out. Okay. Okay, the August date of the physician advisor town hall, I believe it's August 16th, but again, that's not set in stone yet. I'm sure you can go, I'm sure I'll have things out, on our brief, the email that we send out once a week. I'll make sure I get the word out on the dates, who's attending or who's presenting and all of that. Okay. Okay, so how successful are you in getting a readmission denials overturned based on the fact we did everything appropriate with discharge planning? I mean, that is like, a main argument for readmission appeals is that part of it, you're either going to argue or you're going to argue both that they weren't clinically related, and sometimes they are clinically related, just like the gentleman, the toe amputation. To me, those were very much clinically related, but the patient was not compliant. So one of the the things that you're going to argue, I would argue it in every pretty much every readmission appeal, unless they specifically state clinically related or something else that you did everything you could with your discharge planning. So you can't control anything past that, really. You do your discharge planning, any follow-ups, you can make phone calls to the patient. But you can lead the patient to water, but you can't make them drink. So so that is a successful argument based on the fact you did everything appropriate with discharge planning. Okay, Cynthia's asking about COVID and is there government or CMS guidelines to support or dispute? Is there an exemption for COVID remit within 30 days? Cynthia, I'm going to have to research that one. I don't know off the top of my head about any exemptions for COVID, but let me research that one and I'll try to get back to you on that. Okay, Sandra, you've got quite a long question there. At DRG versus per diem payers. Again, let me get back to you on that. Some of these just take a little bit longer to answer. Have you used CMS regulations to on Medicare Advantage readmissions to fight Medicare Advantage readmissions? I really don't, because CMS has really given Medicare Advantage plans a lot of leeway in determining how they pay providers, and it's all based on your contract with them or based on their provider manuals. And it really doesn't, and because CMS's program, readmission program, is so much different than what the commercial payers are doing, I don't use CMS regulations in Medicare Advantage. Oh, and then Claudia has a question about the 72-hour rule, Medicare Advantage denials as readmissions due to services rendered or inclusive within 24 to 72 hours. Okay, so let me get back to you on that one. They're just longer answers. I want to make sure I give you references and everything that you need for those particular questions. Is there an easier way to find these payer policies? Well, I wish there was, right? But every payer is going to have their policies listed on their websites, and so it really is, a matter of having, a policy database so that you have easy access to those policies. Do you have any tips on search words to hunt for supporting research articles regarding appropriate readmissions? Not really. This is from Emily. Not really, because it's not it's not so much about, you know, because so many of the payers they'll have exceptions to readmissions that make sense, you know, so it's appropriate to readmit if they're coming in for cancer treatments, or if they're coming in for, you know, if it's a newborn, or you know, behavioral health admissions and things like that. So it's not so much about, you know, I don't know that there's a lot of scholarly articles out there about when a patient should be hospitalized multiple times, I guess is the best way to say it. So that's kind of my thought on that. Okay, and the Anthem case for the exclusion of sickle cell anemia. Do you find often payers list exclusions, or is that less common in the managed care contract as a go-to document for exclusions? I typically see for the readmission policies, I typically see it in their payer provider manuals, and they're going to list their exclusions there. I'd say it's more often going to be in their manuals rather than in your contracts. Okay, let's see what else we have. Okay, it's another long one. I'm going to go back to that one. The QIO manual, okay. Wow, you guys got some tough questions today. Okay. All right. So some of these questions are, like I said, they're kind of long, which is fine. I don't mind you putting them in there at all, but I just want to make sure that, you know, when I do answer them, what I've been doing for our webinars is taking your questions that come in and doing a Q&A, a written Q&A, and then also a little, it's just a written Q&A that gets posted on our website. And so we'll send that out in the brief when I do get them posted. Like I said, I haven't done them for even the last webinar yet, but I'm going to try to get those out as soon as I can. So thank you for all your questions. They're really good questions, and a lot of little nuances to this problem that I didn't touch on today. So let me see if I can do that through answering your questions that you submitted today. So I'm going to go ahead and wrap it up. I think we're right at the top of the hour. Like I said, thank you to our corporate team. And then if you do think of questions afterwards that you didn't ask, you can always email me at denise@adam.org, ahdm.org. And anything, if you have suggestions for future webinars, of course, you can post that in the survey when you do the survey, or you just email me and let me know what you want to hear about going forward. Okay, thanks everybody. I'm glad I could present this for you. Have a great summer, first day of summer, yesterday, I think. And I will see you in July for the clinical arguments, legal arguments for clinical appeals. Okay, see you then. Thanks everyone.